right, so I'm going to do my best to keep us on time. I have the position to talk about why you should use ureteral access stents during flexible ureteroscopy. And I think there's some very obvious indications here. And because this is a debate, I will be taking the side that we should always be using flexible access or using stents with our ureteroscopy, when in actuality, I don't think we all are dogmatic and do something 100% of the time. With that said, first, my disclosures. I am an advisory board member for several companies. They pay Mayo Clinic, not me. I'm also the dean for our school, so that keeps me busy in some of my spare time. I work for Lumenis, but I'm not a paid consultant for Lumenis. I just use a lot of their toys in terms of lasers and other things. So first of all, when we start talking about ureteral access sheaths during flexible ureteroscopy, I think this has been one of the game changers. Since the very first Teflon ureteral sheath was introduced in 1974 that helped before our ureteroscopes had steerability on them, there's clear advantages to using ureteral access sheaths. One, it protects your instruments, protects your scopes, and I'll share some data with you about that. There's an economic benefit to actually using the sheaths. Not only does it potentially make your surgeries more efficient, but it also protects your equipment, as I said. But not only does it protect the equipment, but it protects the patient, both the ureter and the kidney. It minimizes the pressure that you see in the kidney during flexible ureteroscopy. And importantly, as we start talking about laser technologies and laser lithotripsy, there may be some temperature protective effect. You also have better flow when you're doing flexible ureteroscopy, and visibility is 90% of the game when you're treating complex upper tract stone disease. Also, it's easier to passively eliminate small fragments. You improve the drainage. There's some undisputable evidence that it decreases the infectious complications, and there's some new data emerging how it actually may help with the postoperative period and control pain. So I'll share some of this data with you. First of all, this is probably the biggest study when it comes to flexible ureteroscopy. This is the CROWS database, where they looked at over 2,000 patients across the world. About 67% of these patients had a ureteral access sheath used during their flexible ureteroscopic cases. When they looked at that data, the stone burden in these patients that did have the flexible ureteroscopy, they had bigger stones. About 48% had stones over a centimeter versus those without the sheath tended to have smaller stones. But if you looked at their stone-free rate for just smaller stones, the stone-free rate for patients that had the sheath had a 73% stone-free rate versus only 59% in those that didn't have the ureteral access sheath. And they did some other fancy analysis, and they said, okay, if we took all these patients and we didn't use a sheath at all, their stone-free rate was only going to be 50%. And they said, we're going to take every patient in the cohort and do an analysis. What would their stone-free rate if we used the sheath in everybody? And it was closer to 75%. And this is pretty similar with the evidence from Duke that Jim Esperance came out with early in his experience, showing a stone-free rate of 79% with a sheath versus 67% with a sheath. So right away, we've already established that using a sheath helps improve stone-free rates, and that's why we're doing ureteroscopy, to make these patients stone-free. When we look at complications on these patients, what you see is that obviously if you have a sheath, more of those patients end up getting a stent afterwards, so obviously ureteral access sheath wins that. When you look at the number of failed procedures, actually more people that didn't use ureteral access sheath failed their procedures, so the advantage again goes to ureteral access sheath. When you look at the rates of ureteral perforation, it was pretty much a wash whether you used a sheath or didn't use a sheath. But when you looked at bleeding, the rate of bleeding was less in the ureteral access sheath patients than versus those that didn't. And we're going to talk a little bit more about why that is. When you look at the rates of fever, it advocates towards using a sheath. When you look at the rates of infection, as well as sepsis. And these are important considerations when we're doing ureteroscopy. What about efficiency? So this was a study of a meta-analysis looking and saying, okay, we're going to look at everything out there comparing sheaths to no sheaths. When you look at this giant meta-analysis, you don't have to get into the details of these forest box plots, but importantly what you see is the stone-free rate favors the use of sheath, and even when they did their sub-analysis, the data favored the use of a sheath. So we're establishing quite a track record for using sheaths to help us. This was an interesting study basically that said What about efficiency? So what they did is this was about 257 patients, and if they were unable to pass a ureteral access sheath, they dilated the ureter under direct vision using a semi-rigid scope. And for the most part, they used a 12-14 sheath. But if that patient had a pre-stent, they put in actually a 14-16 ureteral access sheath. And what they found is the patients that didn't have a sheath, maybe their surgeries were a little shorter, but when they had the larger sheath, that 14-16, they had 30% increased efficiency of that. And when you looked at complications, there was no significant increase in complications whether you used a sheath or didn't use a sheath. Lastly, just to put it into context for you, if a patient has a 1 centimeter stone and you fragment that stone into equal pieces, and you have to take those pieces out of either a 12-14 French sheath or a 14-16 sheath, the smaller the sheath, you've got to make about 16 extractions for a 1 centimeter stone. For a 1 centimeter stone with that larger sheath, it's only 10 extractions. And if you double the size of that stone, say it's a 2 centimeter stone and you're going to take all those fragments out, without a sheath, it's 125 passes versus only 75 passes. So clearly the larger sheet does make you a little bit more efficient. But most importantly, let's talk about the pressure phenomenon, because that's really the sweet spot of what sheaths do. One, what sheaths do, they'll increase your fluid rate by 80%. You've got that irrigation so you can see more, so you can do more, and you can maintain it under low pressure. I talked a little bit about the pain mechanism. So we know in the kidney there's mechanical receptors, nociceptors, they're called U1 and U2. 91% of them are U2 receptors. So when the pressure in that collecting system gets over 25 centimeters of water for over 25 seconds, then you start to manifest pain. So a lot of times there's been studies that shown when you leave that stent in and you maintain a low pressure environment in that renal pelvis, those patients have less postoperative pain. And in fact, some people are describing doing perks with the ureteral access sheath in, especially during mini perks, to maintain that low pressure in the collecting system. Just by putting a scope in the ureter, whether it's a semi-rigid or flexible, you're going to increase that renal pelvic pressure to 60 to 100 millimeters of mercury. And we know that pilotubular backflow, pilus venous backflow, and pilolymphatic backflow happen at low temperatures. That's why you get more infectious fevers and everything else associated with it. So this study, everybody knows very well. This is Traxler's study where he documented the terribleness of ureteral access sheaths. They typically used a 12-14 French sheath, and everybody's seen this slide, and you see this horrible slide showing all this damage of what sheaths can do. If you actually read the paper, only about 13% of the time were they a grade 2 or 3 type injury. And what this tells me as a urologist is that sheaths are not ubiquitous and they're not universal. Sometimes you can use a smaller sheath, but if sheath doesn't go up easily, you don't have to place it, or you can use a smaller sheath, or you can come back and fight the risk the other day. The problem with this data set is they told us how terrible sheaths were, but they didn't tell us the long-term consequence of it. In fact, in the paper, they quoted only a 1.6% ureteral stricture rate, and so far to date, nothing in the literature has indicated a correlation between sheath use and ureteral strictures. But Olivier did a follow-up study where he went and said, okay, we came out with that study in 2013. Here we are in 2016. I'm still using ureteral access sheaths 90% of the time. And my best advice for you, if you use a ureteral access sheath, is only operate if the culture is negative. Whenever possible, you should use a sheath for that visibility, just like what we talked about. Try to have gentle irrigation and little manipulation, and avoid prolonged surgery. I think most rule of thumb, whether you operate for an hour and a half to 2 hours, if it's going to be long, you need to have that sheath in, especially for those complications associated with the procedure. And lastly, really talking about avoiding damage to your scope. When you use a sheath, you don't have those insertion forces. You don't have to put your scope over a wire, and that wire can hurt your working channel. In fact, if you look at most forensic evidence on ureteroscopes where they break, is in that working channel. Most of the time it's due to laser damage, but it's also due to guide wires' repeated passage through that working channel. And it's been shown that the use of a ureteral access sheath actually increases the lifespan of your reusable scope 2 times. So you get twice the number of procedures by protecting it and using that ureteral access sheath. And they say that the cost of a sheath is offset on average by a time savings of 10 minutes per case. So in conclusion, when we look at cost, the advantage, maybe you can say that ureteral access sheath costs a little bit more because it adds to the case, but you may have a little bit more savings in that you're being more efficient when your case. When you look at improved vision, there's no question, ureteral access sheath, you can see better because of your irrigation. When you look at the better vision, it's clearly there, the stone-free rate, the data has shown that it is there unless you're dealing with probably small or ureteral stones. When you look at infectious complications, clearly there's an advantage to those that use sheaths. When you look at pain control, there's an emerging amount of evidence that says perhaps there may be some pain controls because you don't stimulate those U2 receptors by maintaining that low pelvic pressure within the kidney itself. There may be some evidence that it's kidney protective because you're preventing pilotubular and pilovenous backflow by maintaining low pressures. And clearly it's ureteral protective because you're not dragging fragments out of that ureter. Now you could also argue if you're not using a sheath and you believe in the school of dusting, you're dusting all that stone so you're not taking fragments out anyway. I would say from a urology standpoint, taking fragment out to get stone analysis is important in terms of our preventive paradigm as well. And then in terms of stricture, there's no data evidencing sheaths to the risk of stricture. So thank you very much.